If you are a medical student or you are a primary care provider, either an internist or a family practice physician, or you are a PA or a nurse practitioner, or you are a general neurologist, this video is for you. Also, if you are just interested in knowing how a movement disorder neurologist make the diagnosis of essential tremor and how they manage these patients, watch this video. Use the chapter description below to navigate to your desired section. Let's start with this case. This is a 55 years old male who started having bilateral hand action abnormal movements when he was a teenager during activities such as writing, eating, when he's using his hands. When he's relaxed, there is no abnormal movements. The abnormal movement got worse during the last 5 years. No new medications, no significant pertinent medical history, including no change in the sense of smell or what we call REM sleep behavior disorder, which are very characteristic for Parkinson's disease, but not necessarily for the diagnosis. The first thing that you need to know is what is the phenomenology. When I say the phenomenology, what are you seeing? He called it tremors. So are these really tremors? Or maybe this is dystonia or myoclonus. That's the most important step, to recognize the pattern. What do you see? Otherwise, you are going to make the incorrect diagnosis and the patient will receive the incorrect treatment. This is a very straightforward case. Some cases are more complex either because they have a combined process or they have many co-founders. In this case, this is a tremor because of the oscillation, the oscillatory movement, which is characteristic for tremor. And this is what we call this phenomenology, tremors. Now let's talk about tremors in details. In tremors, you have two important characteristics. One of them is rhythmicity. It's a rhythmic movement, usually, not always, because sometimes in patients with essential tremors, the tremor looks jerky, but still they have essential tremor, okay? So don't get fooled about that. But by definition, tremors are rhythmic movements. The other characteristic is they are oscillatory movement, which means that they move around a central plane. So this is the plane, and they move around a central plane. This is what we call oscillation, oscillatory movement, different from jerks or myoclonus, which are unidirectional. So one side. So this is a jerk. It's a fast movement. And tremors are like this, oscillatory movement. That's the two main characteristics. Now, these are 4 videos that I have here, 4 patients, 4 different diseases. Now, the first one is a patient with what we call spinocerebellar ataxia, type 2. So, and this is only confirmed by genetic testing. So this patient have a confirmation of the disease, and you see the degree of ataxia. He barely can do tandem gait. Actually, he cannot do tandem gait. This is what we call tandem gait. You can see that with essential tremor as well. You can see the mild ataxia and essential tremor. But in this case, the ataxia, the incoordination is out of proportion from the tremor. He also have a mild head tremors, very characteristic for SCOT2, and some cognitive issues and many other characteristics that I'm not going to talk now. Now, the second video is a classic example of Parkinsonian tremor, resting tremor. Very straightforward case. And when she stand up, you can see the tremor. Very classic. Very classic. Now, the third case is a classic example of essential tremor. So this is a way that you test for resting tremor when the patient are sitting position. I'm going to talk about that more in details later. But when the patient put the hands up, and you will see soon, you see the tremors, mildly asymmetric, more pronounced apparently on the right than the left. And then during kinetic movements, right, finger to nose, you see the severity and actually a little bit of intentional component that you see in patient with essential tremor as well. Now, the last case I have here is what we call functional tremors. Functional tremors. Functional or psychogenic tremor. This is how we used to call it before. Now we call it functional tremors. Very common. Approximately 20% of the patient that we see in the movement disorder clinic, they have functional neurological disorder. And the most common type of phenomenology in functional neurological disorder, functional movement disorder is tremors. After that, dystonia. So the characteristic feature of those patients with functional tremors is that the tremors change in direction very drastically and also location. Location, for example, you have a patient with tremors distally, and then the tremor change to proximally, and even the direction of the tremor change. Also, the frequency changed very drastically. So it's very, very important to pay attention to those details. You see how the patient changed from here to here, and I'm trying here to do entrainment. That you can see that sometimes, but sometimes it's very difficult to get entrainment. So entrainment means that you set the rhythm of the tremor. You, the provider, set the rhythm of the tremor, which you don't see that. You are not expected to see that in organic tremors, okay? Now, before I change a slide, it's very important to be careful about diagnosis patient with functional neurological disorder when they just are bizarre, because there are many things in neurology that they look bizarre, but that doesn't mean that this is functional. Okay, very important. The diagnosis of functional neurological disorder is made by positive finding on exam. Okay, not by ruling out diseases. This is another topic that we will get a video at some point. But functional neurological disorder is always in the differential diagnosis. Now let's talk about classification of the tremor. Well, this is the way that we classify tremor. However, the most important aspect of classification is the activation condition. Now let's talk first about the body distribution, which is location. So this is well, you have to pay attention where exactly you are seeing the tremor. Is it the fingers, the wrist, the shoulder, the head, the jaw, the lower lip, the distal legs, because that might guide you to differential diagnosis. And this is why I put here, for example, when you see a patient with finger tremors during resting, it's most likely Parkinson's disease, but not always, okay? The same thing here. When you see a patient with a wrist tremors at the level of the wrist, this is more characteristic for essential tremor, but that doesn't mean that the patient has essential tremor. So it's more complex than that. One of the important location that almost always you can say that the patient has Parkinson's disease is when you have a patient with a unilateral low frequency resting tremor in the leg, okay? Distal leg resting tremor. So you put a patient supine, resting, and you see the tremor distal leg, then this is most likely a Parkinsonian tremor. Now, the most important thing in tremor classification is the activation condition, which means you need to ask yourself if this is a resting tremor or this is an action tremor, because If you cannot differentiate between these two, then you will have issues making the diagnosis. And the other part is the tremor frequency, which is actually not too helpful. Why? Because the majority of the pathological tremors range from 4 to 8, except the orthostatic tremor, which is a very, very, very rare phenomenon. So those tremors with orthostatic patient orthostatic tremor, the frequency is pretty high, is approximately 18 hertz. Movement disorder, we divide the pathology in two areas, hyperkinetic or hypokinetic. In hyperkinetic movement disorder, we have multiple phenomenologies, many phenomenologies. The most common ones are tremors, myoclonus, and dystonia. Also, a very common one is chorea, but chorea is pretty easy to differentiate from the other ones. The most difficult one to differentiate when your eyes are not trained is a myoclonus dystonia from tremors. Now let's talk about the different phenomenologies that you have to think when you see a patient with tremors. Number one, myoclonus or jerks. So myoclonus sometimes are difficult to differentiate from tremor when your eyes are not trained. By definition, myoclonus is faster, very fast movement, brief. It's like a shock-like involuntary movement. Do you have two types, or negative myoclonus, which is the contraction inhibition, like for example, when you have a patient with renal failure or kidney failure, renal failure, that you put the hands like this in this position and you see this type of movement, which means that the inhibition of the contraction, that's why we call negative myoclonus. Sometimes we see that with bouncing of the gait, when the patient start having knee collapse, bouncing, and you see that when you have an oxybrain injury for hypercapnic respiratory failure. Another reason to have bouncing of the gait is with functional or psychogenic gait, okay? Very common to see that in the clinic, actually. The other type of myoclonus, which is more common, is the positive myoclonus, which is actually a unidirectional. Remember when I say about tremors are oscillatory movement, and myoclonus is one direction, up or down, but not like this. This is oscillatory movement. So in myoclonus, in positive myoclonus, there is a contraction of the muscle, okay? Now, you cannot suppress myoclonus. You cannot suppress myoclonus. This is very characteristic. You might suppress tremors. For example, sometimes when you have a Parkinsonian tremor, it's very common for patients with Parkinson, when they are talking about something else and they're not thinking about the tremor, or you are distracting them, you see the resting tremor. But when they look the tremor goes away. Okay, this is characteristic for Parkinson. Now, the myoclonus might interfere with a motor act. Okay, so that's why sometimes when the patient is telling you that they are dropping things, you start thinking about myoclonus. That might happen with chorea too, but myoclonus is very characteristic that the patient start dropping things. The other thing is characteristic is you do not have the urge or the relief after the movement, different from tics. In tics, patients usually, is part of the characteristic of having tics, is that they have the necessity to perform the movement and they have a relief. This isn't tics. In myoclonus, no. Also, in myoclonus, they don't have sensory tricks. In tics, actually in dystonia, they have sensory tricks. So for example, you will see later that I'm going to talk and I will show you videos about dystonia. Patients sometimes with dystonia of the neck, with tremors, they touch the chin and the tremors get significantly better. Some patients just put something in the back of the head and the tremors get significantly better of the head. So everybody is different in terms of the sensory trick when we are talking about dystonia. But the important part here is that in myoclonus, there is no sensory trick, and this is another way to differentiate phenomenologists. Now, let's talk about, and actually, let's see this video. You see the jerk, the right hand? Let's do it again. You see that? So this is actually a patient with MSA with a postural polymini myoclonus. Okay. Now look this one. Let's do it again. You see how fast is this movement? Now the question here is if this is cortical or non-cortical. That's another topic. Okay, because this patient actually he has a cortical myoclonus. But the point of presenting this video is for you to differentiate between myoclonus and a tremor. This is not a tremor. This is myoclonus. Okay. Now let's talk about the dystonia with tremulous movement. And I say tremulous movement because it's not actually a tremors. It's not actually a tremor because it's not a rhythmic and it's not oscillatory, but looks very tremulous. And that's why we call dystonia with tremulous movement. In other words, dystonic tremors. So these are the difference between dystonic tremors and essential tremor. Number one, as I mentioned before, in essential tremor it has to be rhythmic, but not always. Sometimes patients with essential tremor, they looks very jerky, okay? Now in dystonic tremor, they are really jerky, very, very, very jerky, okay? Now, again, and this is the same, almost the same thing, which is another characteristic of essential tremor is the oscillatory pattern, right? Different from dystonic tremor, they have directionality. So, and or a specific position, a specific position dependent. So which means that there are a specific position, either supination or pronation, that you will see in this guy here, that the tremor get worse. The tremor get worse during a specific direction. Let's see this here.
Oh, like this. Keep like that.
So no tremors, right?
Wow.
No tremors. Well, because it's extended, full extension, full extension.
Put your hand close to you.
And now you will see with inflection,
close to you.
Flexion, you will see the tremor on the right side. That's a position specific, position dependent.
Okay. And then turn like this and slightly.
So it gets better, but when he's supine, it gets worse. When he gets supine, it gets worse. Look at this.
The pronation goes away.
The pronation goes away.
Supine, do this.
Okay. Supine gets worse.
Push like this. And touch your nose with the left. Touch your nose with the left. And back and forth with the left.
So you see that there is no
right. And now
tremors.
do it with the other side, with the right.
And the other side, when he reach the nose, because he's flexing and supinating, you see the tremor. Okay, this patient actually respond very nicely to Botox injection, but the key here is which muscle are you going to inject? That's an art. That's the most difficult part of treating dystonia, dystonic tremors, is to know which muscle are you going to inject. Okay, that's another topic. But my point here is to differentiate that this patient was diagnosed with essential tremor, and he doesn't have essential tremor. He has dystonic tremor. Okay, let's see this one here.
Turn the head to the left.
Turn the head to the left. Look at what she said.
And the tremors almost stop.
Almost stop.
It's a classic.
That's a null point.
Okay.
Null point. We call that the null point.
Turn the head midline.
And you see the jerky tremor. The tremor even get a little bit worse when she
put your hands up
to the right.
Like this. Open your eyes.
And she basically doesn't have any tremor in the hands.
Straight.
It's just abnormal posturing of the hands, spooning of the fingers,
Like this.
and excessive flexion of the wrist.
Okay, perfect.
And actually, if when I evaluate this patient and that I made her walk and on tiptoes, you will see overflow. Okay, overflow, which is a characteristic feature in patient with dystonia, which means that you activate other areas of the body and you see more drastic dystonia. Okay. Now, another thing regarding essential tremor, the next tremors are typically disappear. So in essential tremor, remember essential tremor, when the patient are resting, should not have tremors. Obviously, there are some exceptions to the rule. There are patients that they have, even with essential tremor, resting tremor, approximately 20%. But typically, in the level of the neck, when the patient are relaxed, lying down, facing up, the head tremor goes away. Okay, the neck tremor goes away. And the dystonia, in dystonic tremor, you will see abnormal posturing, dystonia in the muscles involved. Okay. Now, another important thing that you need to see in patient with essential tremor is you need to have hands tremor by definition. So you have a patient with only isolated head tremor. Only isolated head tremor. This is most likely not essential tremor. This is most likely dystonia, okay? So remember that for essential tremor, you need to have hands tremors during action. And I will talk more about that later. Now, another characteristic, very important characteristic that you see in many of these videos, except the sensory trick, is all these characteristic features that we have here, okay, with dystonic tremor. Patient with dystonic tremor, they have sensory trick. Many of them, not all of them, okay? Sensory trick could be just touching the chin. There are some patients that, for example, they put a towel, something on the back of the head because the head jerked too much, and they put something on the back of the head, and the tremor goes away. Okay, the tremor goes away. Overflow, like I say, overflow is you stimulate, you tell the patient to walk on tiptoes or heels, and you will see the dystonic posture more prominent. Another way to do it, if you have a patient with dystonia on the right hand, you make the patient to write with the left, and you will see how the right hand get the dystonic posture. Okay, this is overflow. The null point is this part here.
Like this, open your eyes, turn the head midline.
So the null point is what I described,
It's a classic.
that the patient, when this
Tremors
patient,
almost stop.
with the patient move the neck to the left, the tremor goes away, almost stop.
Midline.
That's the null
Perfect.
point. So basically, the brain is telling her to move the neck to the left, right? So if you allow the brain to take over, everything will be fine, right? But if you fight against your brain and you turn the head to the opposite side, the brain will tell you, no, 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 and let me pull, and start pulling, and then you have the jerky movement, okay? Because you are going against what the brain is telling you. Now, the other thing is, remember what I say, isolated neck tremor is usually dystonia. The other characteristic is neck pain. When you have significant neck pain, it's most likely dystonia. Approximately 70% of the patients with cervical dystonia, they have neck pain. Different from essential tremor. Obviously, people with essential tremor, when you get old, you will have arthritis. And if you shake too much, you will have pain too. So that doesn't help you too much, but usually people with dystonia, cervical dystonia, not the other dystonias, cervical dystonia, patients complain of significant amount of pain and spasms of the neck, very painful. And they respond very nicely to botulinum toxin injections. When you are able to identify the pattern, the phenomenology, so in this case, tremors, then the next step is to be able to tell if the patient is having a resting tremor or an action tremor. We call that the activation of the tremor, right? When it's resting, the body part, the muscles involved are inactive. When it's an action, is used during contraction. The muscles involved are activating. Okay, so resting tremor is very straightforward. I will show you how to evaluate a patient with resting tremor. But in action tremor, you see this case here. So this is a postural. This is what we call postural tremor. Okay, so we divide the action tremors in mostly 3 areas, but for us, most important is the kinetic, which is this one. This is kinetic, finger to nose. You see in this case how the tremor gets worse when he's trying to reach the target. This patient has a little bit more pronounced intentional component or terminal tremor. Would you see this with cerebral tremor, but also with essential tremor as well? Okay, so again, this is how you evaluate for resting tremor. And this is the correct anatomical position. And you will see another video showing that. This is the postural tremor, right? And you see this case asymmetric, right more than left. Okay, and the tremor gets worse during mobility. Okay, this is kinetic, kinetic, and then finger to nose, kinetic. Okay, another way is to tell the patient to drink or to write. So to drink something, so you will see that the tremor get very bad, or writing as well. So this is a typical action kinetic tremor. Okay. Now, in postural tremor, there are 2 types, or position dependent, which is this patient here that we talk. This is a position dependent tremor. Or position independent, right? Which is this patient here. So it doesn't matter the position of the joint, the tremor will be almost the same. It doesn't matter. So this is more characteristic for essential tremor. Position specific, position dependent is characteristic for dystonia. Okay, the kinetic tremor, which is during movements, are divided in these 3. The most important for us is the intentional tremor. And why is so important? Because the physiologic tremor should not have an intentional component. Okay, different from essential tremor and the cerebral tremor, that they have intentional component. And you might ask, why the essential tremor patients they have intentional component? Because the pathology, part of the pathology in patient with essential tremor is coming from the cerebellum. Okay, now the other important area is to know which tremors is predominant, because remember, people with essential tremor, they might have resting tremor 20% of the time. They have resting tremor, but the predominant tremor is kinetic. Okay, they might have postural, but the most important tremor in essential tremor is the kinetic, during action, during movement. Okay, during movement. Now, let's
put your hands up.
Let's evaluate a patient for resting tremor. How do you evaluate a patient with resting tremor? Let's start from the beginning. So this is the anatomical position to evaluate for resting tremor. Patient need to be relaxed without any arm contraction. Okay, if you tell the patient to put the hands like this, like facing up, they are supinating, so they are contracting the supinator muscles, which include the agonist is the bicep, but also the supinator, right? Supinator and the bicep are the main muscle that produce supination. So you need to tell the patient to be relaxed and semi-prone position. Okay, it's a relax. So in other words, if you put the EMG needle right there in any of these muscles, should be silent, should be relaxed. Okay, should be relaxed. Now, if you put a needle in this patient, the bicep might be firing. Why? Because you are activating the muscle. So if you see a tremor in this position, this is not a resting tremor. This is actually an action tremor. Okay, so let's see. So resting tremor, right? There is no resting tremor. And look at the action tremor. A little bit worse, I think, on the right. Okay, significant kinetic tremors as well. Probably the same kinetic and postural. Some people might say that is worse during kinetic. So this is a patient with essential tremor. Okay, now here, look at this position. She's contracting. This is not the correct position to evaluate a patient with resting tremor. This is not the correct position to evaluate a patient with resting tremor. Why? Because she's contracting. So this is not the correct one. Okay, this is the correct one. This is how you are going to check for resting tremor in a sitting position. Now, the best way, some patients you cannot detect the resting tremor, not even telling them to count backward. Sometimes what I do, if we are looking Parkinsonian tremor, is to tell the patient to count backward from 100 by 2. So for example, 100, 98, 96, 94, and keep going. And keep going, and you might see the resting tremor. If I cannot get that, you would be looking during standing position, walking, okay? This is characteristic. When the patient is walking, you can see the characteristic Parkinsonian tremor in some patients. And you will see this in this video. This is got a characteristic resting tremor in a patient standing position. Okay, walking. Now, like I say, in action, in essential tremor, the most important is kinetic. Okay, kinetic should be more pronounced than postural tremor. Kinetic should be more pronounced than postural tremor. And this is characteristic for essential tremor. Now, how common and how prevalent is tremors when we are talking about movement disorder in general? Well, people who practice general neurology and know very well how prevalent is essential tremor and tremors in general, or action tremors in the general population. It is very common. Based on this book, which is probably our Bible in movement disorder, every movement disorder fellowship trained neurologist had read this book probably 3 times. I got this table from this book. You see that essential tremor is one of the most common after RLS. So you see that essential tremor is actually around 5%. And there are some papers that indicate that it's even 7%, 7%. It depends which paper do you read. But in other words, it's a lot of people with essential tremor. The thing is that many of these patients, they don't come to the clinic because they think that it's not a big deal. The tremors are not affecting them. They think that they have the tremor because they are getting old, which is true. When you get older, the chances of you having essential tremor increase. So there are 2 peaks when you get older or when you are in your 20s. Okay, so those patients that get essential tremor during this period when they are 20s, teenagers, they usually have a family history. Okay, they have family history and a slow progression. This group here, when they get tremors after age 60, they progress more quickly and they don't have a significant family history like this group here. Now, if you think that we are good making the diagnosis of essential tremor, think again, because this is not true. This is not what the data show. Actually, if you read this study published in 2006, we are misdiagnosing patients at least 1/3 of the cases. Okay, so those patients that they were misdiagnosed in this study, usually they have diseases like a Parkinson disease, dystonia, or even a combined process between Parkinson disease and essential tremor. Okay, so in summary, 33% or one-third of the patient with tremors, they are misdiagnosed based on this study from New York. Now let's talk about the criteria for essential tremor, exclusion and inclusion criteria. The most important one is that you need to have hands tremors, bilateral hands tremors. Although 5% of the patient initially they might have just unilateral hand tremor, but by definition is a bilateral action tremor for at least 3 years, with or without other tremors in other location. Now, if you have a patient with just started having some hands tremors that seems to looks like essential tremor, but only for 1 year, a few months, then the only thing that you can say and do document is action tremors. You need to wait 3 years. This is an arbitrary number in order to say that the patient has criteria for essential tremor. Probably because there are many things that look like essential tremor, like a physiologic tremor, and I will discuss in a table later how to differentiate physiologic tremor from essential tremor. Now, the other thing is, and this is a very controversial, and this is based on this paper published in 2018 by the Movement Disorder Society. Many people don't believe on this, and it's very controversial, but people who really deal with essential tremor, and they have noticed that many patients, they have some subtle, soft neurological sign, other features. It's not just tremors. There are many patients with essential tremor that they have some dystonic posture, but not enough to call it dystonia, like the patient that I show you on the videos, okay? So other patients, they have a resting tremor in essential tremor. 20% of the patient with essential tremor, they have a resting tremor. And just having that, then you need to call it essential tremor plus, okay? So also gait ataxia. So there are patients and they have, remember what I told you about some more than 50% of the patient with essential tremor, they have ataxia. And ataxia characterized by specifically trunk ataxia, or when they walk, they cannot do tandem gait, okay? Many patients, they have actually, there's some association when you have a late onset of essential tremor to have a at least mild cognitive impairment, the late onset of essential tremor. And some people believe that there are 2 types of essential tremor. So this gets more complex because there are the early onset, which is probably more genetic related, because those patients, they have usually a family history, strong family history, mom, dad, sister, brother with tremors, and they respond better to alcohol. And remember, alcohol, because you might read about that, the alcohol help patient with essential tremor, but usually the alcohol doesn't help you too much, because when you ask patients, the alcohol might help any type of tremors, but there are some specific patients with young onset of essential tremor that they are very sensitive in terms of benefits to alcohol, although the next morning they will shake even more because you have like a rebound effect. So this is when we call essential tremor plus, which means the tremor plus something else, but not enough to call it. It just, you put the plus. So that's why it's so controversial. Now, important thing here is the exclusion criteria, okay? Number one, tremors isolated in the voice or head. This is not essential tremor, this is something else. Look for something else, okay? Now, I will tell you that people with essential tremor, they have a voice tremor in approximately 60-65% of the times. So very, very common. This is why some of the video that I show you, I tell the patient to say because you can see the fluctuation, the oscillatory voice, different from the dystonia. And why I do that, because there are ways to differentiate between a dystonic voice and the tremulous or the essential tremor type of voice. Okay, this is another topic, but it's very important to evaluate the voice as well. Now, if you have a patient with tremors, the tremors are only during specific position, like the guy I show you that only had tremors when he is putting the hand during supination and flexion of the elbow, and the hand is closed like this. This is not essential tremor. This is dystonia. Also, sudden onset. For example, patient woke up today with a tremor out of the blue. This is not essential tremor. This is something else, and most likely is a functional neurologic disorder, a functional tremor, okay? That's why you need to look for other things, other positive findings to make the diagnosis of functional tremors. This is a very important slide. How to differentiate between essential tremor and enhanced physiologic tremor. I'm pretty sure many times you guys are seeing a patient in the clinic with action tremors, and you ask yourself, I am dealing with essential tremor or enhanced physiologic tremor. So this table will help you to make the difference. For example, let's talk about when the tremors involve the neck. So almost always, and I don't want to say always because in medicine nothing is always, but basically almost always, when you have the neck tremor, this is pathological, okay? This is not physiologic, this is pathological. And it's usually essential tremor or dystonia with tremulous movements, okay? So the enhanced physiologic tremor do not affect the neck. The other thing that they help you to differentiate is the intentional or the terminal component of the tremor that you see in essential tremor, but you don't see that in enhanced physiologic tremor. So when I say the terminal or an intentional component is when the patient is reaching the target. For example, your finger or the nose, and the tremor get the amplitude of the tremor get worse. You see the exacerbation of the tremor when the patient is getting to the target. This is what we call the intentional component that you see in patients with essential tremor and cerebral tremor. In cerebral tremor, the frequency of the tremor is lower, and a lot of proximal type of tremor, different from essential tremor that this is more distal. That's another way to differentiate between essential tremor and cerebral tremor. And I mentioned cerebral tremor because you see cerebral tremor, you start thinking in cerebral tremor when you have an intentional component, but again, in essential tremor, you see intentional component as well, okay, 50% of the time. The key here is that there is no intentional component in enhanced physiologic tremor. Now, the other way to make to help you to differentiate is which tremor is predominant, the kinetic or the postural. The kinetic tremor, this tremor, is more prominent in patients with essential tremor, and the postural tremor is more prominent in patients with enhanced physiologic tremor. Okay, this is another one. Then the asymmetry. So you see more asymmetry of the tremor. Sometimes the right more than left, or left more than the right. In essential tremor, in enhanced physiologic tremor or excessive physiologic tremor, it's pretty symmetric on both sides. You see in essential tremor a mild ataxia, mild gait ataxia, trunk ataxia. And you don't see that with enhanced physiologic tremor, unless they are having something else. Remember, many patients, they can have enhanced physiologic tremor, and at the same time, they have a sensory polyneuropathy causing them to have a gait ataxia, sensory ataxia, okay? Now, the resting tremor is present in approximately 20% of the patient with essential tremor, and this is actually a late finding, and almost, I don't want to say never, but usually never, do not involve the legs, okay? Resting tremor, when you see a patient with a resting tremor, make sure it's resting and not action, resting tremor, unilateral in one leg, with a frequency of approximately 4 hertz, like this frequency, is most likely a Parkinsonian tremor. Now, remember that the enhanced physiologic tremor is the most common postural tremor by far. So these two types of tremors that you see here, the essential tremor and enhanced physiologic tremor, are the most common type of tremor that you will see in the clinic by far, more than the tremor of dystonia or the tremor that you see in Parkinson. Okay, this is another important slide because it helps you to differentiate when you have a patient with essential tremor and the tremor that you see in patient with Parkinson's disease. Assuming that you don't have a combined process, okay? Because many times you have a patient that they have a tremor predominant Parkinson's disease that develop after many years of having essential tremor. So many times in the clinic, you see patients with action tremor for more than 30 years, more than 40 years, and now developing a different type of tremors, and now they have bradykinesia. When I say bradykinesia in the setting of Parkinson's disease, I refer to slow movement, but not just slow. You need to have decrement. Decrement in the amplitude and speed of the movement during repetitive maneuvers like a finger tapping, okay? This is a very important and essential to say that the patient has Parkinsonism in the setting of Parkinson's disease. The other thing is in essential tremor, you should not feel rigidity, okay? You can feel paratonia, which is a lack of relaxation, but not rigidity. How do you differentiate rigidity from paratonia? Well, sometimes it's very easy, straightforward, because the patient, sometimes they have significant rigidity. But sometimes you don't know because it's mild and you don't know if this is lack of relaxation, paratonia, or is rigidity coming from the basal ganglion, right? So one way is what we call the Fromen sign, which you tell the patient to open or move the opposite limb. For example, you are checking the left hand, and you tell the patient to open and close the hand of the right hand. Okay, so when it's rigidity from the basal ganglion, you will see exacerbation of the stiffness of the rigidity when you are doing these maneuvers. Okay. If it's paratonia, actually you will see the opposite. You will see a relaxation. Okay, relaxation. So you will see less rigidity. So this is a way to differentiate. And now that we are talking about rigidity, sometimes I see Some doctors document cogwheel rigidity, and this create a lot of confusion because it's better to say cogwheel phenomenon. Why is that? Because the cogwheel phenomenon, you see that in any type of tremor, any patient with tremors, including physiologic tremor, when the patient cannot be relaxed. Now, when you say rigidity, it's different because rigidity should not be present in essential tremor, in pure essential tremor, okay? So the cogwheel phenomenon is the tremor superimposed to the lack of relaxation of the limb that you are moving. That's the cogwheel phenomenon. And you should document like a cogwheel phenomenon and not cogwheel rigidity. Now, the frequency doesn't help you too much. Why? Because pathological frequency overlap. Yeah, this is true that Parkinson's disease tremor, the frequency is a little bit slower compared with the essential tremor. For example, you see here, but this is basically in labs. When you go to the lab and you are able to detect that with electrophysiology, if 5 hertz mostly, and different from the essential tremor, which is 8 hertz. So, but in the real life, in the clinic, this is not going to help you. So the most important thing is which tremors is predominant. This is the question that you need to answer. You need to answer which tremor, which one is the most predominant? Is the kinetic or the resting? And then you will have the diagnosis, okay? This is one of the things that help you the most to differentiate between pure essential tremor and tremor predominant Parkinson's disease, okay? In essential tremor, the kinetic tremor is the predominant. And in Parkinson's disease, the resting tremor is the predominant. Now, location. In essential tremor, the wrist is affected, mostly affected at the level of the wrist, flexion and extension. Now, not always is like that because you will see patient with a combined. It's not just at the level of the wrist. You might also see patients having a little bit of tremors at the level of the elbow with supination and pronation. That typically you see that in Parkinson's disease, but some patients are just so difficult that they have a combination. In Parkinson, it's more common you see tremors at this joint, MCP, okay, MCP, the fingers, but not always because you might see that with ET as well. So that doesn't help you too much, but sometimes it might lead you to think that the patient has Parkinson's disease or essential tremor. Now, jaw. The jaw tremor, that might help you significantly. Why is that? Because jaw tremor in the setting of essential tremor is never appears only at rest. If you have jaw tremors when your mouth is closed and relaxed, close and relax, no contraction, relax and close, then this is not essential tremor because this most likely is Parkinsonian tremor, okay? Now, with essential tremor, you can have jaw tremor, but the predominant tremor is during action, when the mouth is open or when you are talking. When you are talking, the mouth is open, and you see more tremor. This is a classic example of jaw tremors in the setting of essential tremor, okay? Again, this is very important. So far, 2 things are very important in this table. Which tremor is predominant and the jaw tremor. The other one doesn't help you too much, except obviously the bradykinesia. You see bradykinesia, and you feel bradykinesia, and you see bradykinesia or clear rigidity out of proportion of the rigidity and the slow movement that you see in somebody 99 years old, then, that help you. But otherwise, sometimes it's very difficult when it's very mild. And then you just base your assessment in these 2 factors, which tremor is predominant and the jaw tremor. The jaw tremor help you a lot. Now, head. So head tremors, you see that in essential tremor. Okay, you see that, yes. It's a late manifestation, most common in females, but I don't want to talk about statistics because when you see a patient in the clinic, it's just 1 patient. These apply when you see patients as a large group, which is not your case because you are seeing one patient in your clinic and that's it. But if you check the literature, it's most common in female, the head tremor. Head tremor is never seen in Parkinson's disease. It's almost never seen in Parkinson's disease. This is a red flag against Parkinson's disease unless coexist with essential tremor. Okay. Now I have patients, yes, I have patients with Parkinson's disease, with all the criteria for Parkinson's disease, and they have head tremors as well. But those patients, they have significant amount of kinetic tremor. Okay, so most likely they have an overlap between ET and Parkinson's disease. Okay. Now, in essential tremor, when you tell the patient to lie supine, to be supine, facing up, relax, the tremors of the head usually goes away, okay, or decrease significantly, okay? Remember, because essential tremor by definition is an action tremor, different from tremor in Parkinson's disease, which by definition is a resting tremor, although, again, both conditions, they can have the opposite type of tremors. In case of Parkinson's disease, they might have action tremor too, but less predominant, and essential tremor, they might have also resting tremor in 20% of the cases, but less predominant. One of the most important tasks to evaluate in the movement disorder clinic when you are seeing a patient with tremors is the handwriting and the spirals drawing. So when you tell the patient, and these actually take you a few minutes, but give you a lot of information. So, but when you tell the patient to do the spirals, try to demonstrate the task in the air the first time. You tell the patient to do the circles like this, because in that way they will do it in a paper and you can see the side of the spiral. So in people with Parkinson's disease, when they have significant bradykinesia, at least moderate bradykinesia, you see that the spirals are small, very small, compared with a normal person that typically will have a normal spiral drawing. So you see that this is me doing the spiral. I think it's me doing the spiral. And this is a patient with ET. And you see that ET patients on the right hand, they have this typical axis. So you see the tremor here, the axis from 2 to 8. Now you see that with patient with Parkinson's disease too, right? You see the axis in patient with Parkinson's disease. That doesn't help you too much, but it's the size of the spiral and other things that you can see. Also the decrement when you are doing the loops. That I don't have a example here, but when you have a patient with Parkinsonism and you tell the patient to do the loops, you see the decrement of the loops. It's like a cone form, right? So another thing is when you are telling the patient to do the spiral, is to tell them to lift the hand off the paper, okay? Because that will show more the tremor. You will have like a magnification of the tremor when you do that. Now tell the patient also to draw a line, vertical and horizontal, at least 10 centimeters long, so you can have an idea about the frequency that help you in terms of the frequency per second. And the handwriting, try to give a patient to instruct the patient to write a sentence with a lot of vertical letters, such as the H, L, V, and you can see in these letters the oscillation, and even the axis that you see in patient with essential tremor or Parkinson's disease. So let's talk about the last part of this talk, and is the treatment. Unfortunately, we are still using the same medication that we were using 30 years ago. Exactly the same, propranolol and primidone. Nothing new regarding oral medication yet, although there are many studies going on, but still, this is the medication that you guys can take. It's available for patients right now, but it's the same type of medication that doctors already retired many years ago used to offer to patients with essential tremor. So one of the things that you have to think about is when you see a patient with essential tremor is to ask the question. You need to ask yourself, are the tremors enough to require a treatment? And sometimes, many times, it's no. The answer is no, because it's if you have mild tremors and the tremors are not affecting your function, your daily activity, you know what is the best treatment? Nothing. So just watch and wait approach. So many times I see patients with a mild bilateral kinetic tremor, okay, mildly asymmetric. Patient is able to drink, patient is able to eat. They are not dentists, they are not surgeon, so they are not nurses, so they don't, it's not affecting function. So you don't treat those patients. You just follow them up, follow them probably in 1 year or 1.5 years, and you go from there. Now, when the function is affected, with daily activity is affected, then you start thinking about a pharmacological treatment. And the first treatment, if there is no contraindication, is propranolol. So contraindication for propranolol will be severe asthma, moderate to severe asthma. There are some patients who rarely use albuterol, and with intermittent asthma, and we take the risk. So we take the risk, and patients are doing fine, and because they are not using the albuterol. Remember, albuterol is a beta-2 agonist, will cause tremors, will cause an enhanced physiologic tremor, right? So propranolol is my drug of choice, the first choice, because of the safety profile. Okay, other contraindication obviously is a bradykinesia. And so that's the first choice. I always start with 10 milligrams twice daily, and I might go to 3 times a day, and I keep going up based on side effects. My second choice is primidone. Now, if the patient has significant ataxia, walking issues, memory issues, depression, I would not use primidone, because the side effect outweigh the benefit by far. And remember, primidone is metabolized in phenobarbital 25%. And phenobarbital is the medication that I use to induce coma in the neuro ICU years ago. So when you have a patient that require to be in coma because the patient, they have a status epilepticus and nothing is working, phenobarbital is the way to go. So my point here is that phenobarbital, which is 25% of the primidone metabolized to phenobarbital, cause significant sedation and cause ataxia and many other side effects. Is effective? Yes, it's effective. Reduce approximately 60% of the amplitude of the tremor, compared with 50% of propranolol. The third choice is Topamax. Topamax, pretty effective in some patients. They gave Topamax a level of bioevidence. The same thing with gabapentin. Gabapentin is another choice. The doses always start Topamax topiramate. I should write here topiramate. 25 milligrams. Start a low dose always, okay? Low dose. And gabapentin always start a low dose. Don't start 300. That might be too much during the beginning, and then go up every week. Many patients require at least 100 milligrams of Topamax to see something, okay? If they are able to tolerate, and many times they are not able to tolerate Topamax, because remember, essential tremor get worse when you get older, so those patients are more susceptible to have cognitive issues from Topamax. that dopamine might cause cognitive issues, especially language, word finding difficulty problem. Gabapentin is pretty safe from the cognitive standpoint, but it might cause sedation, sleepiness in some patients in a dose-dependent manner, in a dose-dependent effect. When I try, sometimes I actually, after trying propranolol and primidone, I skip this one and I go to Botox injection, botulinum toxin injection, either Botox or Xeomin. I use either or, it doesn't matter. But only if it's only a simple tremor, which if it's a combined or multi-directional tremor, it's not gonna work. It's not gonna work. Every time that I try this, almost always work. When I say work, I mean that decrease the amplitude of tremor approximately 50%. And improve the function of the because that's another question, because you can improve the tremor, but that doesn't translate in improving the function. Function is like eating, like drinking, like writing. So that's the key. That's the most important thing, because I can make the tremor looks beautiful on the spiral. I can show you how with the Botox I can decrease the amplitude of the tremor, but that doesn't mean that the patient is better eating or writing. Okay, that's another question. So my point here is that if the tremor is simple, just extension and flexion, and not a combination of extension, flexion, supination, pronation, and many other directions, then this is not going to work. Okay. Some tremors are complex, and they have those patients, and they have a combination of Parkinson's disease and essential tremor. It's very difficult to treat with Botox. Now, the best treatment, in my opinion, in those severe patients, severe amplitude of the tremor, is deep brain stimulation. They gave here level of C, but this should be changed. It should be level A, because it's just everybody who deal with these type of diseases all the time, like us in the movement disorder clinic, knows how effective is deep brain stimulation in patients with tremors, with action tremor, with essential tremor. And I will talk about that soon. Now, this is a very nice table from this group in 2014, comparing all the medications that we have available to treat tremors, and comparing with deep brain stimulation. And you see, this is the percent of improvement, right? So we talk about propranolol, which is 55%, primidone 60%. We talk about that. Look at the topiramate, improved 40%. But looking at alprazolam, which is a medication that I didn't talk about that, but it's actually I think it's level C of evidence, or B. I don't remember exactly. But I don't use it because I'm concerned about the side effect of alprazolam long term, especially addiction. Alprazolam is Xanax, so it's very addictive. So I don't use it, but tend to be more effective than actually the propranolol. So I have a few patients on alprazolam, but not prescribed by me, by a doctor that was working in my clinic before me, and I have to say that yes, so work in some patients, but I'm concerned about the side effect, especially addiction and the rebound effect. Okay, and there is something that we call tachyphylaxis, that is like it usually help initially, but then the receptors get kind of numb, and you need a higher doses to have the same benefits. So it's like a opioid type of problem. So that's why benzodiazepine, I don't use benzodiazepine for tremors at all. Now, when you see here, how good is the deep brain stimulation? Okay. And long term, look at this long term. Now, This is another device, and this device is relatively new. Basically, this is a sophisticated device that looks and feels like a watch, and it stimulates the radial nerve and the median nerve, radial nerve and the median nerve at the level of the wrist, and cause similar effect that the deep brain stimulation, similar effect that the deep brain stimulation at the level of the thalamus, okay? The specific nucleus that we call the VIM, and basically disrupt the pathological oscillation at that level, okay? Very safe. The only thing is that you cannot use in patients susceptible for seizure, like patient with epilepsy, because technically might trigger a seizure. And also you cannot use in patient when they have another electrical devices like a pacemaker or pain stimulator. If you want more information about Cala, okay, and especially about insurance, because the VA patients and some Medicare patients, it might cover, there's some insurance coverage, which is the main problem in my opinion. You can go to the website and get more information about that. But I personally don't have any patient with this at this time. And this is basically the graphic, a figure from the website, from this website, showing that how that work, and the median nerve and radial nerve is stimulating the thalamus. Okay. Now, let me show you this video. This is a very, very important video because I want to show you how deep brain stimulation work with tremors. Pay attention to this. Let's watch the first video. So this is a patient with history of action tremor for more than 40 years. More than 40 years, okay? So very severe tremor. I think this is one of the worst cases I ever seen with tremors. One day, this lady, the battery, so battery was empty basically. So can you imagine this patient without the deep brain stimulation? Let me show you.
So you start having tremors when you turn 40. Okay, now
She's almost 80.
Turn the DBS off.
So I turn it off now.
And see what happens.
Look at that.
You leave the left on. Okay, that's okay.
So it's during. So it's even worse when she leaves the arm.
Turn this on again.
So I turn this on.
A lot better. Right?
Lots better.
So tremor goes away in seconds. So that's amazing. Okay, now let's see this one here. So this is a patient who, I don't remember why we did only unilateral. I don't remember, but we did this patient unilateral, only on the right. Maybe because she was having significant ataxia, something like that, but I don't remember details. But look at this. This is off. Sorry for the quality of the video, but you see the action tremor, and you see the kinetic tremor, very pronounced.
Perfect.
Very pronounced. Now let's turn this on. Look at this. A lot better. A lot better. Let's do this again. A lot better. Okay. So this really works. Really work very well. But again, in the appropriate patients, patient selection is the most important step. And obviously you need to have a good neurosurgeon, fellowship trained in functional neurological, in functional fellowship trained in functional neurosurgery. Very important. Otherwise, things are not going to work well. The main side effect that you have with deep brain stimulation is balance issues, voice issues, problems, especially when you do it bilaterally. Okay, usually those side effects are very mild, and patients are very, very happy with the tremor control, which is the main goal.
Oh,
Now, the other procedure available is what we call the MRI ultrasound. MRI ultrasound. So unfortunately, we don't have this in the area where I work, but tend to be very effective. It's a relatively new. It's not new. It has been performed in Europe for many years already, but approved by FDA, I believe, in 2017 or 16. And I have a few patients only with this procedure, and 2 of them are doing pretty well. And the other 2, and they end up having deep brain stimulation anyway. So the side effect would be paresthesias, imbalance, dysarthria, which is articulation problem with the articulation of words, and but tend to be very effective. And the good thing about this is nobody is opening your head, but literally they are burning your thalamus. The same nucleus that you stimulate with deep brain stimulation is the area that will be basically burning to decrease the tremors significantly in patients with essential tremor, and also approved for tremor predominant Parkinson disease, or the tremor that you see in patients with Parkinson disease. If you like this video, don't forget to subscribe to my channel. See you soon.